How's everybody doing? Yeah? You need a deep breath after that. This is not going to be anything like that because we're going to talk about some cases here. I might, depending on time, just do one case because we're a little late. But I'm hoping I can make this interactive, and I can only do that with your help. So we'll give this a try. I'm going to name you Team A and Team B, and I'm going to give you a chance, Team A over here, to respond, and Team B to respond. We'll try to go back and forth like that. So I named this the games people play. That's your first clue. All right, everybody ready? All right, this is a 3-year-old male castrate dachshund that presented for lethargy, vomiting, and diarrhea, 1 week duration. So it's a sick dog, and I just want to remind you that I work in a lab. I look at numbers all the time, and you're a veterinarian. So sometimes I don't know all of this clinical information, which can be very helpful. So we want to make sure we pay attention to the signalment and presenting clinical signs for this case. So does anybody have the diagnosis? Team A? And it could be Addison's disease, right? You may have something that in the laboratory data that may support that, but we'll move through some lab data since that's what we're going to talk about here. On the physical exam, the dog had pale icteric mucous membranes and a grade 3 systolic murmur, and shockingly, a pack cell volume of 8. We hardly ever see single-digit pack cell volumes in dogs, sometimes in cats. All right, Team A, you have your diagnosis? Yeah? Team B? Okay, good. Somebody said IMHA, and I really think that needs to be on your list of differentials, right? If you're looking at dogs that have marked anemia, IMHA can be a cause of that, but let's see if we can get any additional information from looking at that hematocrit tube. If I tell you that this dog's hematocrit tube is the one on the left, what else do you notice about that? Yeah, it's hemolyzed, right? Markedly hemolyzed. So could that fit a diagnosis of IMHA? Well, it could be something that's not IMHA. It could be some other cause of hemolytic anemia, like a oxidative damage to the red cells, like onion toxicity or garlic toxicity or something like that. So what I want to do is look at some numbers. You already now have a pack cell volume, and you could easily measure the total protein, but let's see if we get any additional information. Okay, so here's the CBC. And again, like Steve, I sort of forgot when we go through the profile data to switch over to systems international units. But you have the reference intervals there, so I think you can still see even when we get to the profile what's normal and what's abnormal. So what do you think about the plasma protein? It's high, right? Any explanations for that? Good, because we know the animal had vomiting and diarrhea, so I think that's the easiest explanation. Could there be some interference from that marked hemolysis? This is a refractometer-determined plasma protein, so I think that also could be a cause. What else? What's on your other short list for increase in plasma protein? I like really short lists, so mine only usually have 1 or 2. Good, inflammation, right? So we have evidence for dehydration in this dog. We know it came in with a history of vomiting and diarrhea. Do we have any evidence for inflammation? Sure, what's the evidence there, Team A? Bands, right? So this animal has leukocytosis due to neutrophily with a left shift, and that certainly supports inflammation. So I think we have good explanations for why that plasma protein is 9. All right, Team B, this is a markedly anemic animal. Does it have regenerative or non-regenerative anemia? Regenerative anemia, right? So that makes your list really short. It has to be hemorrhage or hemolysis, right? Not likely hemorrhage, at least external hemorrhage because the plasma protein is high, but we don't know that for sure. We'd have to go back and ask the owner any evidence for blood loss or hemorrhage in the urine or GI tract. So if you have an animal that has a regenerative anemia, what do you expect the MCV and MCHC to be? Team A? Which one's high? MCV or MCHC or both? MCV, right? Because those are less mature red blood cells, so they're bigger. We don't have that here, right? So that doesn't exactly fit. I don't have a good explanation for that. What about the MCHC in a regenerative anemia? What do you think that should be? They're less mature red blood cells. Yeah, right? It should be low. So they should be macrocytic, hypochromic. Huh. Right? So that doesn't fit here. So why do you think this dog has an increased MCHC? That's a really high MCHC. You already told me. So team B? Why do you think that MCHC is high? Yeah, it's got hemolysis, right? So even if you hadn't done your own packed cell volume and looked at that hematocrit tube, once you saw the results back from the CBC, you would still conclude that this animal had hemolytic anemia. Is it intra or extravascular hemolysis we're talking about here? Intravascular hemolysis, good. Okay, so we have not a very long list of things that cause intravascular hemolysis. What's on your list? Toxins like onion toxicity. So we've got a couple votes for onion toxicity. Anything else? Like? Sure. So Babesia is what I think of for intravascular hemolysis, so that could be a cause. And early in the discussion, we talked about IMHA. Can that cause intravascular hemolysis? Sure. So I think we still have to keep all of those things on our list. What about the RDW here? Do you guys remember what that is? So it stands for red cell distribution width. And that is the coefficient of variation of red cell size. And the reason that value was developed is in human medicine, nobody wants to touch the blood, right? They just want to run it through an instrument. It's too expensive for somebody to touch it because it takes longer and there's such a risk of infectious disease. So this is just an index of variation in red cell size. So if you have an animal that has a regenerative response, we'd expect that to be high, right? There's more variation in red cell size. So that kind of fits here. What about the platelets? We have to worry about those? They're normal, so we don't really have to worry about platelets. We already talked about the leukocytosis, neutrophil, and the left shift. But now we have these nucleated red blood cells. What do you think we should do with those? We could ignore them, or we could come. I'm sorry?
It's been happening for a few days.
Yeah, so the way I tend to think about nucleated red blood cells most of the time, if the animal has a regenerative response, I'm not too worried about them. I think one explanation could be that this animal is so anemic, there's probably hypoxic damage to the endothelial cells in the bone marrow, and that kind of helps control when those nucleated red blood cells get in circulation. I'm not worried about them because the animal has such a markedly regenerative response. So we had this differential of Addison's disease because the animal presented with vomiting and diarrhea. It was a sick dog. That anemia wouldn't be typical of Addison's disease, but there is something on this CBC that sometimes you might use as a way to think about Addison's disease in an animal that has vomiting and diarrhea. Anybody think about what that is? What haven't we talked about yet? what do you expect the lymphocytes to be in an animal that's sick? Low, right? And so for me, if I have a dog that's sick and I expect the stress response for lymphocytes, which would be lymphopenia, and I don't see that, I might entertain Addison's as a differential, but it doesn't fit with everything else that we've been talking about. And then the monocytes here are high, which could be part of inflammation, but any animal that has hemolytic anemia likely will have monocytosis. And then eosinophils here could be normal or increased. So, you know, we talked a lot about laboratory data, but now we have to narrow our list of differentials mostly to decide what are we going to do next and how are we going to talk to the owner. So what do you want to do next? Team A, do you have the next step here you want to do? What about you, Team B? So you can do a biochemical profile. That's going to cost more money, right? Team A, you guys have something back there you want to do?
We agree with biochemistry.
Biochemical profile? That's what everybody wants to do? Okay, agglutination. You could look for agglutination if you're suspecting IMHA. Yes. Who said that? Yes. Blood smear. So I'm all about looking at the blood smear, especially if you have an animal that has regenerative anemia. The non-regenerative anemias, the red blood cell morphology is usually not very exciting, but if you have an animal that has a regenerative anemia, sometimes you get some really helpful information. What if it's a hemotropic parasite? Will looking at the blood smear help? Sure. What if the animal has IMHA? Will looking at the blood smear help? Sure. What if the animal has oxidative damage from eating onions? Yeah, so the blood smear might give us a lot of information. So we'll let you look at that. I think we talked about all of these differentials, except for we didn't really talk about intrinsic red cell defects, and they almost never will be the cause of that because they're so unusual.
Isn't this doctoral?
Yes, right, the age would be unlikely here for an intrinsic red cell defect. But since Dr. DiBartola talked a lot about the serum biochemical profile, we probably should pay a little attention to the biochemical profile. So what do you guys think about the BUN and creatinine here? Cystog azotemic? Yes. So then for me, because I take a very simplified approach to this initially, you would want to know if that's pre-renal, renal, or post-renal, or could be a combination of things, right? So what do you think in an animal that has a plasma protein of 9 and presented for vomiting and diarrhea? Do you think there could be a pre-renal component? Sure. We can't rule out renal yet. What other piece of information would we want in addition to that BUN and creatinine, right? Urine-specific gravity. And the phosphorus is high, probably because there's decreased GFR. What else do you want to worry about there? Anything? The AST? Sure, the AST is really high. Anybody have any ideas of why that might be true? Muscle damage, do you have anything else to support that? So there could be some muscle damage. The animal's really anemic. Good, CK, right? So that's going to also support that there probably is some contribution of muscle damage. Some of that AST could come from hemolyzed red cells. What else? So you guys sort of skipped over the anion gap. And even though the bicarbonate is 16, it's low normal. So can we talk about that a little bit? What do you think of the anion gap? It's increased? What does that mean? Does anybody remember? If it's high, So it usually means that there's some unmeasured anions there, right? You have unmeasured anions. I don't know, do you guys use the abbreviation LUKES here? How do you remember your mnemonic for things that could contribute to an increased anion gap? Anything? Does anybody have any differentials? You just don't want to think about it because you can't remember anything on the list. Yeah, I sometimes have wanted to use that approach, but I think we probably should think of a few things. So we used LUKES. I don't know who came up with that. There probably are other ones people use. Lactic acidosis, uremia, ketoacidosis, ethylene glycol, and salicylates, which we never see in veterinary medicine. So you can just remember LUKE. If you want to remember a mnemonic, that's been really helpful for me. So do you think this animal could have lactic acidosis? What makes you think that it could? Yeah, exactly. It's got a PCV of 9, so I'm pretty sure it's not oxygenating the tissues very well. Do you have any evidence that there could be some uremic toxins there? Sure. So there may be a couple things contributing to that increased anion gap. And the bicarbonate for me is a little lower than you'd expect to see in a normal animal. It's low normal. What if it were 15 and I could actually say the bicarbonate's too low? What did Steve just mention would be the most likely cause of a low bicarbonate? So I mostly think it's likely metabolic acidosis, right? If you really wanted to pursue that, what would you do next? What other laboratory tests might be? Blood gas, sure, which I don't have on this particular dog. Okay, so let's look at the rest of this so we don't have to worry about the cholesterol. Oh, wait, that bilirubin is really high. Why do you think that bilirubin is high? Sure, the hemolysis, right? That'd be the most likely contributor here because the animal has that marked hemolytic anemia. And then here we can see that the total protein is high, not as high as it was on the refractometer, but it's still mildly increased, mostly due to high globulin, and we already had evidence for inflammation here. The glucose is normal. The hemolytic index, which our instrument gives, is really high because we know the animal had that marked hemolysis. And then we didn't get a complete urinalysis on this dog, but we have a urine-specific gravity of 1047, which would suggest that much of that azotemia could be pre-renal. You'd want to recheck that after rehydrating the animal. Why do you think that urine was so reddish-brown? Hemolysis? What else? Yeah, so I think in this dog you can't really tell because it has evidence for some muscle damage and some hemoglobinemia and hemoglobinuria. Okay, so you guys wanted a profile. We gave that information. Did that help you? So we're still trying to figure out why this dog had marked hemolytic anemia. So for me, this would be a case where another approach could have been just having somebody look at the blood smear, right? This may not change your approach too much without first having seen the blood smear. Okay, so I think we talked about all of that. So here it is. And can I walk away from here? I can't because that is on. So I'm going to do this team A, team B, so now you have to respond because I'm going to make everybody participate here. Team A, you get to tell me one thing that you see on that blood smear. If I tell you this is representative of the blood smear and you didn't know anything else about this dog, what would be one thing you could tell from that blood smear? Okay, spherocytes. So team B, do you agree with that? Do you see spherocytes? So now you're going to treat this dog for IMHA? Okay, so what if I tell you that this is not a spherocyte, this is not a spherocyte, that's not a spherocyte, and that's not a spherocyte? And you're all going to go, well, why are you saying that, right? They look darker red, they look a little smaller, but they're not very smooth, and there's something else about those red cells. So team B, what else do you see? There is a picture perfect something else that you see on that blood smear. But there are lots of other things you can say if you don't see the picture perfect. Somebody sees a Heinz body. The picture perfect Heinz body is right here, right? This little protrusion from that red blood cell. So I'm hoping everybody would have seen that as a Heinz body, but if you didn't see that, the more difficult ones to see are here. Here, this one has two. This red blood cell has one, this red blood cell has one, this red blood cell has one. It's just that most of those other red blood cells, you're looking down on top of them, it makes them harder to see. This one is really clear, textbook version of a Heinz body. So now you're going to rearrange your list of differentials and move IMHA down on your list and something that causes oxidative damage to the red cells higher up on your list. But we want to mention a few other things on this blood smear because I really want you to be able to see some of these other changes. If you didn't have the numbers on the CBC, would you be worried about platelets in this animal? No, lots of platelets there. Would you have thought that this animal was anemic? Sure, there's so much space around all of these red blood cells. Would you have thought it was a regenerative anemia? Polychromatophilic cell here. Target cells, we don't really think too much about those. But there's one other change here I want to see if you guys can see, and that's this cell and this cell and this cell here. Can everybody see those? And those are ghost red blood cells because this animal had intravascular hemolysis. And even on those ghost cells, you can see the Heinz bodies. So the key features here are an animal that was markedly anemic. It's a regenerative anemia, and it is due to some kind of oxidative damage that's causing Heinz bodies and intravascular hemolysis. Okay, Team A, I'm giving you another shot at the diagnosis. You guys have the diagnosis yet? Team B? Ethylene glycol? So maybe some toxicity. So put together an animal that is markedly anemic and has intravascular hemolysis with an animal that presented with GI signs, I would be thinking maybe of some toxicity. So now what do you want to do? You know, so my job behind the microscope is pretty easy. I've already identified all of these things, but you have to decide, well, what am I going to do now to determine what caused this marked hemolytic anemia in this dog? Because you have to manage the patient and go talk to the owner. So now you've already done a very partial urinalysis, serum biochemical profile, and a CBC. You looked at the blood smear. You did all of the things you were supposed to do. What are you going to do if you think it may have been acetaminophen toxicity? Sure. I mean, you can always go back and talk to the owner, and maybe the owner didn't remember, or you didn't ask the question a specific way. Did your dog have onions? We've certainly seen that at Ohio State. We have a restaurant called Outback Steakhouse that has this bloomin' onion. It's like this huge plate of fried onions, and owners almost never can eat them all, so they come home and feed them to their dogs as a special treat, and then they get onion toxicity. I'm sorry?
Does it do the same to us?
I don't think so, and it doesn't do that to all dogs. So the question is, it may give you a GI upset, but I don't think it causes hemolytic anemia. But it doesn't in all dogs either, but it does in some dogs, and they get pretty sick from that. So go talk to the owner, and the owner can't remember anything that this dog ate. It hasn't been exposed to any drugs like that, but you still have to decide what you're going to do next. What if you missed those Heinz bodies? And we don't do this as much anymore because our instrumentation now counts reticulocytes, but you could do a new methylene blue stain. And if you miss the Heinz bodies here, you can see them here. So that's a Heinz body, there's a Heinz body, And these are the reticulocytes from the regenerative response. Okay, well, I don't think the next thing you're going to do is talk to the owner about the mechanism of Heinz body formation, right? You're still going to have to figure out why this dog has this. We talked about onions. We see these with red maple leaf toxicity in horses. There are other plant toxins that cause Heinz bodies. Acetaminophen's on our list, so I think it's certainly worth questioning the owner about that. There's a long list of chemicals and drugs that can be associated. So I think it's worth sometimes going back and asking the owner very specific questions. But that's not what the cause was in this animal. So I just remember this case because I'm sitting there looking at this blood smear trying to figure out what would cause Heinz body hemolytic anemia in this dog that has not been exposed to any of these. So we have to remember that there are other causes of Heinz bodies like zinc. And zinc comes in many forms, comes in ointments, bolts, pennies, and Monopoly pieces. So this is the games people play. And this is the deluxe version of Monopoly, which has the metal pieces. It costs like $150 US. It's really expensive. We don't have it. We have the little plastic pieces in our Monopoly game. But this family had this deluxe version of Monopoly, and everybody's favorite piece is the top hat. That's everybody's favorite piece if you take a vote. And that was this dog's favorite piece also. So here's the top hat. There's the top hat. So it's a great example of, if you remember, putting together with really, and you guys recognize that right from the beginning, that this dog had presenting signs that didn't really fit with IMHA, and then just putting that together. There aren't a lot of things that cause that GI signs and marked hemolytic anemia. Unfortunately, zinc toxicity is also associated with pancreatitis, and this dog did not do well in managing the pancreatitis, but they were able to remove the zinc foreign body. So,
Did that take a team diagnosis?
I'm sorry?
Was it a team that arrived at this
A
diagnosis?
team diagnosis. The radiologist figured it out pretty quick. So, yeah. So, are you guys? Do you want me to stop there, or because it's 20 till 10? You guys did a great job. Thank you for participating.
Thank you, Maxine. Look, the United's getting
I was just wondering if you have seen cases like at market elevated urea, but rather high normal creatinine. So on the scale like the B1 maybe greater than 130 milligrams per deciliter, so above the IDEXX measure, and even potentially about 2 micrograms per deciliter.
So you're asking what can cause the situation with very markedly elevated urea but not as marked elevation of creatinine?
Yeah, I was wondering if any like the GI bleeding can actually cause an elevation of B1 of like the greater than 130.
Use this. Can you hear me like that?
Yeah.
Can you hear that okay better? Is that still on? So the question is, what sort of things you think about when the BUN is up out of proportion to the creatinine? And you mentioned one of those is GI hemorrhage, for the reasons we talked about, hyperproteinemia for the bacteria in the gut. That's probably not the most common one, though. Actually, the most common situation where you see the BUN up out of proportion to the creatinine is actually when a significant part of the azotemia is pre-renal. And that relates to what we said about how urea is handled by the kidney. So urea is filtered, but it does experience passive reabsorption, which is related to how dehydrated the animal is. So when you can have a dog that's severely dehydrated, and that urea can be passively reabsorbed, making the BUN go up even before the GFR goes down much. Okay, so when you see the BUN up out of proportion to the creatinine in an animal that's got clinical signs that are compatible with it being dehydrated, like say vomiting and anorexia and so forth, I'd say that's probably the more common reason. Those are the two big ones. So an animal where the azotemia is primarily prerenal or GI bleeding. And the way you answer the question is, the easiest way to answer the question is giving fluids, and if it resolves, then it was probably prerenal. It was prerenal if it resolves. Those are the two big ones. Other questions for any of the three of us? Yes? Okay.
I just wanted to make sure I had it right. Before when you're talking about SDMA production or it getting released into the bloodstream, that it was when the cells died that it's
Yeah.
released?
So yeah, when the cells die, they're broken down and the STI gets released into circulation in that sense. So it's just with cell turnover.
Yeah. So with conditions of necrosis, would you expect an increased production? Or
Not necessarily necrosis. There are some neoplastic diseases where the STMA can increase, and potentially it's because of some structural changes in the kidney that might occur with that. So there are some, lymphoma can be an example where in some settings you'll have a much more, maybe only a normal creatinine or a mild increase in creatinine and a more marked elevation in SDMA, potentially some structural changes in the kidney or a functional change, and that will seem to settle down if they go into remission with therapy with that. And it's one of the reasons I think maybe the STI is a little higher in puppies with sort of greater cell turnover with growth. Any other questions? If not,
Okay.
hand back to you, sir.
Thanks, Graham. Yes. So look, we are at the end of the night, so if you wouldn't mind just putting your hand together again for the fluid. Some good information, or at least a bit of a refresher on some of the things that you may have heard and learned a long time ago. Just a couple of closing points. There is an attendance certificate in your folders here, so just if you want to take that away. The other thing is, if you want to claim the CPD points, then obviously your AVA registration number is probably very helpful. So if you haven't given it already, if you know the registration number, you can give it to our guys on the way out. So that just might be helpful. So apart from that, we will be sending out an email in the next little while just to really get some feedback from you guys. So it'd be great to hear what you thought tonight and how we can improve things going forward. So thank you very much. Drive safely.
I think you can just